We are going to start in 2 minutes. One more minute. All right, let's get started. Hello, everyone, and welcome to Minnesota HIMSS Clinical Informatics webinar series. It's my pleasure to introduce our today's speaker, Dr. Saif Khairat. He is an associate professor at University of North Carolina at Chapel Hill. He holds joint appointment at the Carolina Health Informatics Program, Cecil Shipps Center for Health Service Research and School of Nursing. He is also director of the Carolina Applied Informatics Research Group. With over a decade of the experience, Dr. Khairat has led numerous national and international funded projects to enhance healthcare services and research, specialty with the informatic world. His research agenda focuses on health IT usability to improve patient safety. As informatic expert, Dr. Khairat focused on using novel mixed methods data collection approach coupled with complex data analysis for big data set. He is well known for his novel use of eye tracking technologies to improve and use safety of electronic health record. He has authored more than 65 scientific articles in peer-reviewed journals and conferences, and he is a served as investigator for more than 5 millions in research grant over the past 5 years. Dr. Khairat is a leader with the American Medical Informatics Association. He was inducted among the inaugural class of the Fellows of AMI in 2019. He serves as a chair for Education Committee, and he earned his PhD in Health Informatics and Bachelor and Master in Computer Science from University of Missouri, and MPH in Health Policy and Management from Jennings School of Global Health at University of North Carolina at Chapel Hill. Today, he is going to talk about usability, historical pain point, fundamentals, user-centered design principles. Welcome.
Thank you so much, Dr. Hrastovic. It's my pleasure to be here and to be speaking to the HIMSS Minnesota chapter. Today, we'll spend some time talking about electronic health records usability, the notorious pain points that people have been complaining of for a number of years, and then ways to mitigate those pain points using user-centered design and usability testing. So we'll talk about we have four different sections in today's presentation. Pain points in the EHR, the importance of usability, and user-centered design, and some evaluation methods that we can use to assess our design of electronic health records or other tools to assess its effectiveness and performance. So to begin, this is one of the earlier pictures or paintings of a physician in the previous century. As you can see here in this painting, the physician wearing a red robe sitting on a chair is looking deeply into the patient, a little girl, and you can see the girl's family sitting in the background. It's important for us to look at this picture and look at the care that we provide today to patients and how things have changed. As you can see in this image, there are no computers, no bedside alerts, no technology disruptions. There's really just quiet time to focus on the patient and to try to analyze and assess the patient condition. Moving to 2021, this picture really doesn't exist as much as it used to be, due to the fact that we have to use electronic health records to document and store and retrieve patient information. So some background about the use of electronic health records. It has been documented and verified that the use of EHRs is directly associated to provider burnout. If you haven't had a chance to read the book by Atul Gawande, Why Doctors Hate Their Computers, I suggest taking a look at that amazing book, and it's a great read on what really are the pain points of using EHRs. Mainly, frustrations around the design of EHRs have been associated with high dissatisfaction rates among providers. Physicians gave EHR a failing grade on its usability, and similarly, satisfaction is not improving over time. The poor EHR usability leads to less face-to-face time with the patient, as we saw in the first painting that I was showing, more provider exhaustion and burnout, and higher risk of medical errors. So poor usability and suboptimum design of EHR is a problem with significant impact on clinical care and patient safety. More than half of doctors say they're burnout, and close to 90% say that they are moderately to severely stressed, and 60%, close to 60%, wouldn't recommend a career in medicine to their children. Now, if we do the math, EHR is attributed to burnout, and burnout is widely spread among our clinicians and providers. That also increases the importance of solving the usability issues in our EHR system. One of the main pain points in using the EHR is the amount of data that a clinician is exposed to at any given time. So in this study here, they show that the average data points per day for a patient can go up to over 2,000 data points in a given day. And for a 24-bed ICU, it can go to up to 50,000 data points. The challenge of having too much data is, there are several challenges. First, it's hard to sift through all this data and make timely decisions and accurate assessments. Also, exposing clinicians to a lot of data has implications on their cognitive capacity. It slows them down, and it also affects their information processing abilities. So too much information, although it's great on the back end to have as many data points as possible, we have to think about ways to present those data points and which data points to be presented to providers. When asked about the number and the severity of usability problems, you can see that clinical summary and CPOEs, computerized provider order entry systems, had the highest amount of usability issues. You can also see that the major issues are also within those two, in addition to problem list. But also looking at this figure, you see that almost every single aspect of the EHR has some sort of a usability concern or issue, whether it's minor or major. And so that tells us that there's not just one area of the EHR that needs to be heavily revamped and redesigned, but it's more of a comprehensive revamp of the whole interface design, both for design and for functionality. So the problem is, as we expose clinicians to more data, the human cognitive capacity is able to process 5 sets of facts to make a given decision. However, in 2020, clinicians and in general, human beings are being exposed to close to 1,000 data points to make a given decision, which is far beyond our cognitive abilities. So we see that providers spend on average 16 minutes per encounter using the EHR. And the chart review is where they spend most of the time. Chart review is where a lot of the information about the patient exists, documentation from the past, and also documenting what the plan and the plan of care moving forward. So a lot of people spend time in chart review. As you're going through the system and you're either looking up patient information, you're exposed to close to 1,500 individual data points. Providers process an average of 200 variables in each visit. Tie that with the figure on the right, where the normal human capacity should have an optimum number of 5 facts versus 200. And think about the consequences of too much information presented to the provider. ICU providers have to monitor about 2.5 million data points over 31-day period and respond to close to 200 alerts per patient per day. So that's a pain point, and a lot of clinicians who have to deal with decision support systems and alerts will always say that they're alert fatigue or alert numb after a given number of alerts. Their concentration on muting those alerts are increasing. And so we can see from this slide that too much information is a problem, too much disruption is another problem and a pain point. And so we need to think about ways to minimize the information we present on the screen, and also the number of times that we absolutely have to disrupt or pause the clinician's interaction with the EHR. In one study, we looked at how long does it take a physician to experience fatigue using the EHR. We found that, and that was using physiologic data based on pupil size. So using eye tracking technology to understand at what point does a person experience physiologic fatigue. We found that 80% of our physicians experience fatigue within 22 minutes of continuous EHR use, and experienced a second instance of fatigue shortly after that first instance. And 100% of all our physicians experience fatigue within 36 minutes or within half an hour. Now, half an hour a day is not really a lot of time. It's not people spend a lot more than half an hour in the EHR in a given day. And so what is the long-term effect of being fatigued from the continuous use of the EHR? Can we also think about introducing policy changes where maybe the EHR screen can gray out at 20 minutes and give the clinician a 30-second break to recalibrate, refresh, and come back strong enough like they're supposed to be. So if we know that at 20 minutes, most people are experiencing fatigue, what can we do to stop that and to improve EHR use? We also found that experiencing fatigue is not really the main problem. The main problem is in the consequence of what happens after the provider experiences fatigue. We found that after experiencing an instance of fatigueness, the provider is less efficient. It takes them more time to complete a patient case or a task in the EHR, and it takes significantly more mouse clicks to complete a task. So not just are they fatigued, it is also impacting their efficiency and performance in the EHR, where they're slower and it's taking them longer and more effort to complete a case or a task. There's also the other point of electronic documentation as a main pain point. In a nursing survey of more than 7,000 nurses, 72% of respondents said they had to stay after shift to finish their documentation. Less than half said occasionally, a quarter said frequently, and 9% said almost every shift. One NP or nurse practitioner said, you have the choice of either garbage in, garbage out to be on time, or doing a decent job and working longer hours for free. So the study notes that nurses spend between 20 to 60% of their time documenting in the EHR. That's a substantial amount of time that is supposed to be given to patient interaction or patient care. Instead, they're taking care of the computer and of the EHR. What does this all mean? All these pain points and frustrations with the EHR. Well, it makes an unhappy EHR user. People complain that the EHR is slowing them down. They're not able to see as many patients as they used to. Their practice, if it's a small, a private practice, will experience a hit in revenue, and also the continuous upgrading and updating of coding standards, ICD 9, 10, 11, and others, is a continuous effort to stay on top of things for interoperability. So it's an ongoing, continuous effort. We also looked at the differences between two physicians at one department using the EHR. We found some striking differences in their time in the system. For what we refer to as a high-performing or a highly efficient physician, spend on average 55 minutes per day in using the EHR, versus a less efficient physician used the system for 176, with a difference of 2 hours in a given day. 2 hours is a lot of time. Could be directed towards leisure, family, reading a book. Rather, that person has to spend 2 extra hours in using the EHR, which poses the question of why are we seeing significant variations between providers when using the EHR? One idea may be the effectiveness of the current EHR training strategies. So as you may know, right now, most EHR training classrooms is a didactic setup where a class of providers come into the classroom. It is led by an instructor who walks people through the EHR, and then they're gone. But there's really not a tailored or customized EHR training mechanism that addresses the 4 different learning types of human beings. So not everyone is visual or can follow and learn from a didactic training module. And therefore that poses the question of, are we training our providers the right training to use the EHR in the most efficient way? So when speaking about efficiency, we also see that there are significant differences in between sexes. So men were taking a little bit more time to complete some tasks in the EHR compared to women. Similarly, fellows seem to be the most efficient with time, followed by residents, and then attendings were taking the longest amount of time. Similarly here for clicks on the second row, you see that men used more clicks than women, and similarly residents were clicking away more than attending, who would spend less clicks but more time on a given screen. So another pain point of the EHR is the poor support for cognitive tasks and workflow. Wasting time looking for the right information is a notorious problem in the EHR. Potentially selecting wrong data is another pain point, and missing important information from all that data that's being presented to us is something that is probable, which increases the risk for medical errors happening. We also found that another pain point is when asking residents to prescribe a medication, specifically for taper. We found that in one site, close to 50% of our subjects or providers made an error in prescribing prednisone taper to the patients. So 50% and administering and putting in an order seems like a very high number, and putting in the wrong dose for that medication is also scary and frightening, and is a matter of functionality in the EHR. The problem is, to wrap all this together, is we emphasize on humans trying to fit the machine. This is a very famous example from aviation, where this plane crashed. The reason why is, you see the number here in the red arrow is -28. So the pilot thought it was -28 when it was a -2.8. So we need to flip it, where the machine fits the human expectations and not vice versa. So let's talk about ways to mitigate these problems. User-centered design principles. What is user-centered design, or UCD? It is based on, you have 2 ways of doing UCD. Either based on expertise or based on participation. When basing it on expertise, we look for an expert as a designer. So that would be a web designer, a product designer, who has been designing products for a long time and can help us design a user-centered design tool. The other school of thought is based on participation. We get a domain expert, let's say in the ICU, we get a domain expert who knows the highest priority data that they need 80% of the time. And so these are real users who will tell us exactly what they would like to see on the screen and how can we design the interface to better serve their needs. Why is it important? It decreases the time from buying it to using the EHR, reduces cost, makes the development process quicker, and allows for innovative and usable products across the organization. If you're asking for user involvement, some of the methods that we typically use are interviews and surveys, focus groups, think aloud protocols, using eye tracking, and field studies, observational studies, when we go and we shadow the provider as they interact with the system. This is first-hand experience and allows us to see for ourselves what the user is experiencing, and then also what are their opinions on challenges and barriers from their experience. There is the Maguire framework, which is very famous in the user-centered design. Basically breaks down the process into 5 steps: planning, and that includes what are we trying to accomplish, the context of use, so who are the users, doing needs assessment, and then the requirements of the users, designing a prototype and brainstorming ways to improve that prototype, and then building it, and then coming back and evaluating, did we meet our initial objectives or not? So there are 3 main steps in UCD. First one is to understand who is my audience, who is my user. We do that by understanding the characteristics of the user, their education levels, their age, computer experience, culture, time to learn a new application. So it's a comprehensive user analysis. Why that's important is because these are the people who will end up using the system. And if we don't design the system based on their characteristics and preferences, it's not going to be a very effective tool. Next is the task analysis, where we look at identifying what are the steps to get from point A to point B. What does the person have to do? And what information needs to be processed to put in an order or to discharge the patient, so to achieve a given goal. And then finally, doing a cognitive task analysis to define and describe the GOMS, which is goals, operators, methods, and selection rules. There are usability attributes that were defined by Nielsen, who is the godfather of usability, or very famous usability expert, and those were introduced many years ago, but we're still trying to implement them in the EHRs. So simple in language, natural dialogue, consistency, making sure that it's feedback, allowing for shortcuts like dot phrases and smart sets, good error messages that are not overwhelming, and then help and documentation available when people get stuck. Very important attributes as we think about how do we want to design or redesign an existing application that we have. So let's talk about a little bit about usability. Why is usability important? It's a key driver for patient safety. Makes people happy and makes their job a lot easier. What is usability according to Nielsen? It's the ease of learning a system. How easy can I learn it? How easy can I use the system? The ease of remembering. If I go on vacation for a couple of months and I come back, or a couple of weeks and I come back, can I use the system as efficiently as I used to before vacation? Satisfaction is the big thing. Efficiency and effectiveness. Effectiveness is measured as minimizing the number of errors that a person encounters during their task in the EHR. It is defined as the effectiveness, efficiency, and satisfaction. I typically tell people that usability has 3 main outcomes. Effectiveness, and that is looking at the percent of success in completing your tasks. Efficiency, which is related to time. And satisfaction, which is related to the user experience in using this product or EHR. But usability, those may sound easy, is typically difficult to evaluate and to measure. The idea is to bring people in front of the screen and to have them complete a set of tasks or simulation cases, and then we record the time, the clicks, the surveys for satisfaction to analyze where they are in how is their usability experience. So you may ask, why don't a lot of people do usability evaluation? takes a lot of time. Sometimes it is expensive. Those eye tracking glasses can range from $20,000, well, from $5,000 to $20,000, depending on the quality and the accuracy. It's not really an essential for some organizations or vendors to do usability testing. So you just develop it and sell it. And also, they can afford to learn about user problems during the go live session, which is something we try to avoid doing. And also, really, in all honesty, developers who may have an IT background but not a clinical background may not really know what to look for when doing usability testing. That's why we need informaticians and data scientists who can bridge IT and clinical to be able to better understand where are the clinical problems or the clinical implications. This is just a nice figure that shows if you do usability testing early on in the development, you can cost you a couple of dollars to $10. While if you do it in development, it is estimated to be between $500 and $1,000. So huge difference. It's much better to do it early on when you're designing, to think about usability early on. So usability evaluation methods. If you have an existing tool or you're thinking of, I really want to assess how usable or user-friendly this tool is for my department or for my unit, here are some methods that you can use. Usability testing, you use that when you want to identify problems. So you collect data around objective data for task completion time, error rates, and then subjective data on satisfaction and experiences. And then that's a mixed methods approach that will provide a very comprehensive insight into where the problems are. You can do that in a controlled user testing facility where you have, just like in this picture, and actually this picture is from the University of Minnesota, where I used to be before coming to UNC. And this was a state-of-the-art usability lab where there's a participatory suite where you see the participant is sitting and engaging with the computer. And then there's an observation suite where these people are taking notes. They're also watching the participant through cameras. And that glass window is a one-way, they can see the participant, but the participant cannot see the observers. So you can do that in a controlled simulation environment. You have to create scenarios and patient cases, but it gives you the ability to do mixed methods, just like we mentioned earlier. The beauty of doing controlled testing is it uncovers interface design flaws. You can take that back to the vendor or to the developer and say, we need to fix how we put our orders, or we need to fix how we present the information, and so on and so forth. The other school of thought is to do think aloud protocols, where you invite someone to your lab or office space and you have them interact with the EHR and they speak out their thoughts as they're going through completing the tasks. So they would say things like, oh, I am not sure where I can't find BMI. So you can note that, okay, there's difficulty finding BMI on the screen. So they're speaking out their thoughts, and that helps the observers and the researchers understand where the problems lie. So it provides information on design problems and the ease of learnability. Eye tracking has been great. It's been used in other fields like in industrial engineering, and in recent years, it's been introduced in healthcare. Really provides a lot of great data on physiologic performance. So we look at blinking rates, and as people get tired, their blinking rate slows down. We look at pupil dilation and pupil constriction, which allows us to understand when are they excited and when are they really fatigued and overloaded. Also helps us understand where the eyes fixated the most. In essence, on a given screen, do they spend most of the time looking at the flow sheet or looking at vital signs, or neither? Are there areas of interest in the EHR screen, or what I like to call areas of negligence, where no one really looks at these data values or data points? And so the question is, why have them when no one's actually using them? Evaluating learnability is very important. It's the time it takes a user to reach system proficiency, where you can simply say that this person is proficient in the EHR system. Just like we say, and some people say on their CVs, proficient in Microsoft Word or Excel. We need to get to that point or stage where we have proficiency in the EHR. We're able to objectively measure it, and that is, there's different ways of doing it. But the common measure is time to achieve full proficiency in the system. Like you're able to find information within a decent time frame. You're able to remember where things are, what icons to look for, and what icons look like after you've completed the task, so it sticks in your memory. The time you spend looking for help, of course, the shorter time that someone seeks help or finds help, the better. The time it takes to complete a task after being on vacation, the time it takes to perform a task compared to an expert. So you have to have a baseline or a gold standard, and then that's how you assess if that person is proficient or not. You can do that through one-on-one testing and what we call cognitive walkthrough, where you have someone go through a list of tasks and you measure time as they're completing those steps. Subjective analysis is very important for satisfaction. There are a number of surveys for usability. SUS is a very common one, and the quiz. But this is a list of surveys, validated instruments that you can use pre and post implementation to understand if the system after the redesign is useful, is helpful, is better, or it's not really improving the user experience. Heuristic evaluation is another way to look at your user-centered design, whether it's robust or not. Typically, we need 3 to 5 evaluators. And this is a nice figure here that shows, between 3 and 5, you're hitting close to 70 to 85%, or 70 to 80% of the usability errors. So 3 to 5 people can expose close to 80% of your problems, versus from 5 to 15, you're really just getting to that extra 20%. So it's good to start with 3 to 5 and then expand after that. Helps with listing the problems based on severity and provides recommendations for redesign. Very important to mention that when doing user-centered design analysis, we really are interested in improving effectiveness, which is the percent of tasks completed correctly. Efficiency, how long does it take to complete those tasks? And then the enjoyment and satisfaction of our users. So those are the 3 main outcomes that I would always emphasize are of importance. So in summary, usability issues in the EHRs are many. But probably the more important ones are the poor organization and display of information. Overly cluttered screens. Information is scattered over many screens. And in some cases, the same information exists in more than one screen, which is redundant. One of the notorious things that we found was in a given EHR, vital signs in data in one screen was very different from another. And it turns out that one screen was being updated more frequently than the other. So think about a provider relying on the older data rather than the newer data. So information organization and making sure that we display the right information to the right person at the right time is a big usability pain point, and one that can be solved by asking domain experts. What information needs to be on this screen, and how can we present that information? Interference with practice workflow. The disruption is killing really the EHR experience. The amount of scrolling up and down pages and pages of text, lists of options that are not really grouped in a meaningful fashion, and then the lack of integration between systems, EHRs and pharmacy information systems. The other pain point that is of importance is the cognitive burden. Failure to cluster information in a meaningful way results in a user who's overwhelmed and overloaded with information, results in lack of making accurate assessments in a timely fashion, and can create patient safety hazards and risks. For example, naming conventions, abnormal versus high versus upper panic, absolute panic. Having consistency in how we capture data and present the data is very important. Of course, excessive alerts. That is a chronic pain point. Alert fatigue and the recurrence of alert fatigue is something that we have no solution for as of now or today, but things that people are working towards in many places. How can we offer alerts that are not excessive, but are important and timely? And how do we differentiate between an alert that can be overridden by the user versus one that cannot? These are all questions that we're still trying to figure out. Another pain point is the poor design of system functions. Excessive use of copying and pasting. Of course, if you talk to an auditor, they'll say that the copying and pasting of notes in the EHR results in note bloating, where you have a note that just runs on and on and on, and who's going to read all that? Clinical note format. We need to standardize how our clinical notes are, and so that's why smart sets and the dot phrases are being more promoted at the organizational level, and then limited options to adequately document conditions instead of open free text. The other things that are also we need to be mindful of are sometimes there are no alerts to save data. The same widget, but has different functionality in one outpatient versus the inpatient. The scrolling horizontally is another catastrophe because it affects just the experience of having to go left, right, and then toggling back and forth. And then having multiple windows for multiple patients open at once can be tricky and can be misleading in some cases, especially if there's continuous data that's being updated constantly. So in conclusion, usability studies are critical and absolutely essential for an improved health IT integration and for improved and higher patient safety levels. One way to do that is through user-centered interface design that will also offer more buy-in from our end users and less resistance, and will also reveal a lot of usability and design issues upfront that we can fix. And then when we come to go live, we have a more robust system that the majority of our users like and are excited to use. And then finally, there are multiple usability evaluation tools that we've talked about today. There are objective measures like time and percent of errors. And there are subjective measures by surveys and questionnaires and interviews. There's also the heuristic evaluation of having 3 to 5 experts test the system. So those are ways that we can validate if our user-centered design principles or practices were effective and did they meet the expectations of our users and of the organization. So with that, I will stop here and thank you very much for your time and happy to take any questions.
Thank you, Saif, for this presentation, and this is very, very, very useful to group to understand this like problems and how this originate and so on. Okay, we are open for questions. Please use Q&A button on the bottom of your Zoom screen or chat window. Type your question there. Looks like there are one question is in the Q&A window already.
Vitaly, I can't see that question. I can only see a couple of comments.
Okay, the question is, do you have any thoughts on the utilization of standardized clinical decision support tools and whether this would increase or decrease CVL? For example, there could be more alert, but also there could be provide benefits to support decision.
The clinical decision support it's very tricky. Their use, their implementation, and evaluation are very tricky. I say that because we found that it's really subjective. One person does not mind being stopped or interrupted at any point during the process, versus others prefer not to be disrupted unless it's very critical. So from a usability and acceptance standpoint, it's very challenging to come up with a standard CDSS best practice that you can apply to a unit or to an organization. Whether this would increase CDW, I'm not sure what CDW, what does that stand for? Vitaly, do you have an idea?
No, sorry.
Cognitive workload, yes. Thank you. I would say my hypothesis, and it's not tested, that it would improve cognitive workload, but I haven't seen a study that has tested that. It's a great question. I think this is something that we should investigate. It's a great question.
Yeah, as we await another question, actually, I have one more question for you. I mean, there are some obvious solutions how to fix usability problem, and or there are already suggestions how to fix some EMR problems on the usability. But can you comment why EMR vendors sometimes resistant to implement these changes?
That's a great question, a tricky one. I think in my experience, I think things have changed. And yes, you're right. A few years ago, and there was some resistance from vendors to take those usability studies findings and implement them. I think back then it was not something on their radar because it was more about responding to the market. There was a need, people wanted an EHR, and so it was more about implementing. Now that most medical centers, if not all medical centers, have an EHR, I have found in my experience with certain EHR vendors that they are open to making changes. The problem happens when there are too many requests to make changes, specifically from one organization. Then they start saying, okay, well, which one would you like us to change? And in some cases, if you make one change, it makes one group of users happy and another group unhappy. So that's why I think they have been a little reluctant to take some of these research findings to practice. I also want to say that, you know, we have seen recently recent reports that major EHR vendors have been recruiting usability specialists and IT design specialists to start incorporating that within their development process. So I think there is a new culture within EHR vendor companies to begin integrating user-centered design and usability within their development cycle. Yeah, so hopefully we'll see more academic vendor partnerships that can help improve that. Right now, we do research, we publish, and sometimes it just stays there. We need to be able to close the loop, right? Going back to the vendor and say, look, we found this, can we make some changes?
Okay, there are one more question in Q&A window.
In terms of fatigue from working with the EHR for too many hours, has there been any work in collaboration with the field of industrial organization psychology, a research area that studies work-life balance, taking breaks at work? Not that I know of, but we should. We have done, we're wrapping a study here at UNC where we're introducing one-on-one elbow support coaching sessions to providers. And we're trying to assess the pre-coaching and post-coaching if it has an improvement or if it has improved the well-being of providers. In the sense, did we save them some time that they can now use towards other things in life outside of work? We're still working on that study. It's in its final stages. It's a randomized study. We have a control group that we didn't do, we just monitored, no intervention. And then another group that we introduced the one-on-one coaching sessions where we used audit logs to inform the training session. So for example, we have a provider. We went through the last 3 months of their audit log in the EHR. We identified that they spend most of their time in the in-basket and most of their effort in documentation. So we tailored the 1-hour coaching session to solve these two problems, in-basket and documentation, by giving them tips, some guidance around what to do and what not to do. And then we monitor after the coaching session 3 months afterwards to see if that session was helpful on their well-being. So we're still trying to find out if there are if we can improve work-life balance through some informatics initiatives, but I'm not sure. And I think I think having a collaboration with industry engineers who have done this in their field for a long time would be very helpful for us. It's a great question.
All right. Looks like we have 5 minutes left, and there are no more questions. Probably, yeah. We finish our presentation, finish our webinar. There are contact information of Dr. Kairat on the screen. Feel free to contact him with questions, and thank you so much for your time in this webinar. Thank you.
Thank you so much, Dr. Rasevich, and thank you, everyone.
Yeah, bye.